Good evening, everyone. Can you hear me? Good. My name is Frank Brown, at least that's what it says here. And I'm a community member of the Miracle of Living Planning Committee. Welcome to the Miracle of Living tonight. Here are a few housekeeping things we need to talk about. Anybody here got cell phones? Please turn them off. That's very important. For those who need restrooms later, they're located in the lobby area. When you go to the exit doors that side, they're at the back of the conference room, okay? Our lectures are videotaped. Do you all know that? They are all, and they do offer daytime showings of those lectures to those who couldn't get here this evening. The video replay will be coming out on Monday at 10 a.m. and reservations are required. The videos are also available for purchase. It's, what did I say, it's $15 for a DVD and an order sheet. You can get an order sheet in the lobby when you leave. Our speakers will reply from the side stage panel, and papers and pencils are available if you don't have them for the question and answer session that will come later. Lastly, at the close of the program, fill out and return your evaluation form. We need the feedback from you. And you may drop it at the back of the counter too. Our next program next month will be on June 19th, and it's all about the bladder. Oh, we all have those. Okay. We're going to begin our program. I'm going to introduce a few of our people here. Our speakers, we have three. We're fortunate having three. Damian F. Goldberg, MD, is board certified in ophthalmology. Dr. Goldberg completed his internship and received his degree in medicine from Georgetown University School of Medicine. His residency was completed at the Washington National Eye Center, and his fellowship was completed at the University of Texas Health Center. Dr. Goldberg has been on the staff here at Torrance Memorial since 2005, and he's in practice here in the South Bay. He's the guy in the middle. Raise your hand. Dr. Julie L. Gasperini, is that correct? Yeah. She's board certified in ophthalmology. Her area of specialty is retina surgery, okay? Dr. Gasperini received her undergraduate degree at Michigan State University and her medical degree at Wayne State University School of Medicine. She completed her residency at Kresge Eye Institute at Wayne State University and her fellowship at the Doheny Eye Institute here in Los Angeles. Dr. Gasperini has been with the Torrance Memorial Medical Center since 2010, and she practices in Torrance, Seal Beach, and South Coast Retinal Center. And John Maher, Dr. Maher, a friend of mine. John Maher is board certified in ophthalmology. He's the tall one on the far end. He received his medical degree from Stritch Medical School of Loyola University in Washington. Dr. Maher's expertise include laser vision correction, keratotomy, and integrative medicine. Dr. Maher has been in practice in the South Bay for 27 years, and he's been on the staff here since 1987. And our moderator tonight is one of my compatriots on the Miracle of Living board, and his name is Frank Miles. So without any further ado, I will turn it over. Here's Frank. Give a round of Frank. The other Frank. There are two Franks here.
Okay, are we ready? Is the camera going? I've got the signal. Okay. Good evening and welcome to the Miracle of Living. Tonight's program is Here's Looking at You, more than just getting the right glasses. We have three speakers. The first is Dr. Julie Gasperini, second will be Dr. John Maher, and third will be Dr. Damian Goldberg. After they speak, we will have a 10-minute break, And during that time, members of the Miracle of Living Committee will circulate among you, passing out paper and pencils so that you can write questions. And after the break, the doctors will answer the questions. Now, Dr. Gasperini.
Good evening. Thank you, everybody, for spending your evening with us. I'm going to talk about age-related macular degeneration, and hopefully I can give you some insight about what this disease is and what our current treatments are. Since we have had new treatments in the last 5 years, we hear about this condition quite often in the news. I'm part of the South Coast Retina Center, a subspecialty group of retina specialists that subspecialize in diseases of the retina and vitreous in both medical and surgical treatment, and we have various offices and one here in Torrance. In fact, I see some of my patients in the crowd tonight, which is nice. I'm going to talk about the retina, which is in the back of the eye. I like to think about the retina as like a thin piece of tissue where all the central vision comes from. I often use the analogy with my patients that it's like the wallpaper in the room, if you will. And there's very sensitive tissue in the macula, and that's part of the eye that is damaged or becomes deteriorated in macular degeneration. So the macula is a very small area in the retina, and it's the light-sensitive tissue that lines the back of the eye. Here is a blown-up view of the macula, the optic nerve, the blood vessels, and here is the very central part of the vision. And it's the part of the retina that is responsible for you to see fine details clearly. So if you're looking at faces or threading a needle or reading small print, that's the part of the eye that you're using to do those things. Here's an OCT scan of the cross-sectional view of the retina, and the very fine foveal center here, which is the finest central portion of the macula, is that little dip, and this is normal anatomy. In your peripheral or your side vision, the peripheral retina allows you to see with your side vision, and that is spared in macular degeneration. So AMD is another way to abbreviate this condition, and it's the leading cause of central vision loss in people over age 50, and it affects more than 17 million people. Fortunately, 85 to 90% of the cases are the dry form or the non-exudative form of macular degeneration, which tends to be much more slowly progressive. 10% of cases, approximately 2 million, are the wet or exudative or neovascular form of macular degeneration. And the prevalence of this condition is just continuing to rise dramatically. And we're estimating 200,000 new cases of wet macular degeneration every year. So this affects a lot of people. The general symptoms of macular degeneration can cause blurriness or dark areas or distortion of your central vision, since this condition affects the macula. It doesn't usually affect our side or peripheral vision. And when macular degeneration does lead to loss of vision, although it's a bilateral condition, it can be very asymmetric, and it often just presents in one eye. And sometimes people describe macular degeneration as they have a difficult time seeing a face, but they can see the hands and the rest of the body because it affects your central vision and not your peripheral vision. So there's two types of macular degeneration. There's a dry form and a wet form. And first we're going to talk about the dry form, where you get aging and thinning of the tissues of the macula. And the most common hallmark is drusen. They're tiny yellow or white pieces of fatty protein that form underneath the retina. And eventually the macula may become thinner called geographic atrophy, and those retinal photoreceptor cells stop working. And here's a cross-sectional view of these little bumps here are those drusenoid or drusen deposits underneath the retina. With dry macular degeneration, vision loss is usually very gradual. And people who develop dry macular degeneration, we recommend constant monitoring of their central vision with what's called an Amsler grid. In macular degeneration, you may see distortion or waviness or curviness to the Amsler grid, and it's a way to monitor any changes in your vision. The signs and symptoms of dry macular degeneration can be quite broad. Some people just describe it as a blurriness to their vision. Others have a more difficult time reading, and they may need more bright light for reading. That is one of the symptoms of macular degeneration. They may have a difficult time seeing when going from a bright light to low light levels, such as when you're entering a dimly lit room from the bright indoors. They may describe it as a difficult time recognizing people's faces when it gets more advanced, or a blank or blurry spot in the central vision. And it can affect one or both eyes. The wet form, or exudative or neovascular form of wet macular degeneration causes abnormal blood vessels to grow underneath the retina, and it's called choroidal neovascularization. So here's this cross-sectional view of our retina. Underneath the retina is a layer called the choroid, and it causes these abnormal blood vessels to grow, and these abnormal blood vessels can leak fluid or blood into the retina or under the retina, and that's what causes the distortion or blurring of vision. There is about a 50% risk of developing wet macular degeneration in the fellow eye once you have it in one eye. And the importance of knowing these symptoms is that the earlier we can start treating this condition, the better we have to improve or maintain the vision. The signs and symptoms of wet macular degeneration can develop much quicker than dry macular degeneration, and it can progress much faster without treatment. And oftentimes people present with complaints of distorted lines, or seeing a dark gray spot or blank spot in the vision, and loss of central vision. Because of the swelling in the retina, they may say objects in one eye seem larger or smaller than the other eye. The hallmark of the wet macular degeneration is a choroidal neovascular membrane. Unfortunately, not all my pictures are showing up here, but this, when you look at it, sometimes the findings can be subtle. This little red area is a retinal hemorrhage, and this is the choroidal neovascular membrane, which is much more prominent on our fluorescein angiogram, but these images are not showing up. Oh, there it is. So that's why. So in this picture, when we inject dye in the vein, we can clearly see this big dark spot in the center, which is the blood, and the white area is the abnormal blood vessels. So it's very prominent on this test, although it may be much more difficult to see on a clinical exam. This is a much more extreme version of more end-stage macular degeneration, where there's extensive bleeding that's involving the entire macula, and a more end-stage form where there's scar tissue that is developed involving the central vision. So how do you diagnose this condition? Well, dilated eye exams are very important to diagnose, and it is the American Academy of Ophthalmology does recommend yearly dilated eye exams in anybody over the age of 60. If you go to a retina specialist or ophthalmologist's office to diagnose or treat this condition, you may hear about an OCT, or optical coherence tomography. That's this test here that we do, and it's kind of like an ultrasound for the eye, but except it uses light waves and takes simultaneous pictures of the retina, and we can actually look at the retina in even a movie format and look at 500 to 1,000 scans of the retina at one time. And the fluorescein angiogram is this test up here, where we inject a vegetable-based dye into the veins of the arm. And as that dye travels through the blood vessels, they light up. So in this diagram, the blood has already went through these vessels. This one is dark because it hasn't filled. And this lets us look at abnormal blood vessels that can leak fluid. So these are the types of diagnostic tests that we use. So what are the risk factors for macular degeneration? Aging is the most common risk factor, and that's why the disease is becoming much more prevalent is because we're living much longer. And this is not a condition that we see in the 30s, 40s, and 50s. We see macular degeneration in the 60s, 70s, and 80s. And the risk of developing macular degeneration jumps from 2% in their 50s to 30% of people in over age 75. So age is the biggest risk factor for this condition. Other risk factors are oxidative stress. Our body is constantly producing these oxygen-free radicals that over time can damage cells. And we're finding that 1 in 3 Caucasian patients have genetic changes that make them more prone to damage from oxidative stress, puts them at more risk for developing macular degeneration. And heredity is another big factor. This condition tends to run in families, not always. I have a strong family history of this condition in my family. And we're starting to do a lot of genetic testing and linking genes to macular degeneration. One of the most common ones is a complement factor H, which is allowing for a lot more research, because macular degeneration, we lump macular degeneration into one, title, but it can act very differently amongst various patients. Even people with wet macular degeneration in 2 eyes can be, in each of their eye in the same person, can behave differently to treatment. So it's a very interesting condition that we're still learning lots about. Inflammation, overactive immune system has been found to be linked to macular degeneration. Smoking is a huge one. We all know smoking is bad for everything, and here's another thing it's bad for. Smoking does make macular degeneration worse. It's linked to wet macular degeneration as well as hypertension. And obesity may be linked to an increased chance of the dry form progressing to the wet form of macular degeneration. So just like many other conditions, systemic health is very important in macular degeneration, and optimizing risk factors like maintaining good blood pressure control, eating a healthy diet, and stopping smoking are very important. There has been lots of genetic testing that has come out lately, and I get this question not as commonly even from my patients, but their family members. Should I have genetic testing done to see what are my risk factors? And the genetic testing has really come a long way, but at this point in time, the American Academy of Ophthalmology is really advising against genetic testing. And this stance may change, though, as we learn more and more. And I think we will. I think we're going to find we're going to be able to eventually tailor our treatments based on patients' genetic predisposition, but we're not quite there yet. And Ed Stone, I just put in a few quotations from Ed Stone, because in the future, he says, genetic testing will likely allow clinicians to provide mechanism-specific treatments to patients at high risk for some molecular forms of macular degeneration. But at the present time, the costs and risks are outweighing the benefits of this testing. And much of this testing gets marketed directly to patients, and that's why I thought it was important to bring this up. He also said 3 things need to occur before genetic testing will be very clinically useful in macular degeneration. First, we need evidence-based tests to show that knowing the genetic testing will improve the outcomes in patients. We need to have lower testing costs. And then if someone does have a positive genetic test, we have to make sure that there's enough people out there to counsel patients on genetic testing. So although I think in the future, genetic testing is going to be integral probably to the treatment. Right now, we're not quite there, but that I suspect will change. So what is the treatment for these conditions? Well, injections, diet, and vitamin supplements are all treatments for macular degeneration. The most important study that was done for dry macular degeneration is the ARID study, and I'm not sure if you've read or heard about that study, but it's a very important study. It was done in 2001, and for the dry form of macular degeneration, the only proven treatment has been these vitamin or antioxidant mineral supplements, and they have been shown to decrease the risk of progression to advanced forms of macular degeneration by 25%. And this was a huge study. It was a randomized clinical trial done over several years, over 5,000 subjects to look at high-dose micronutrient supplements. And they looked at patients that both had dry macular degeneration and patients that did not. And it was only found to be effective in patients who actually had intermediate or advanced macular degeneration. So I get this question a lot from my patients that don't have macular degeneration because they see these vitamin supplements. There's dozens of them in the pharmacy, and they say, should I be taking this? Well, based on our evidence-based medicine, unless you have intermediate macular degeneration or worse, you really shouldn't be taking these high-dose vitamin supplements because they're not proven to work. However, I do recommend a good vitamin and a good healthy diet for all patients, but they are very effective in patients that have macular degeneration. And I have some slides about what that formulation is, because it can be very confusing to patients because there's so many options out there. Now, very interesting, the ARIDS-2 study, that study data just came out in the last 2 weeks, so it's kind of hot off the presses. This was another huge follow-up study of 4,000 patients, and they wanted to look at if we add omega-3 fatty acids, lutein, zeaxanthine, remove beta-carotene, and reduce zinc in the vitamin supplements, is that going to be effective? And this is called the ARIDS-2 study, and you see lots of vitamin supplements that are already put on the market even before these study results came out because they were anticipating that these things were going to make a difference. Well, interestingly, adding the omega-3 fatty acids, although they're good for lots of things, and I think cardiologists are using them a lot now for cardiovascular health, and they're finding they're very beneficial, but in macular degeneration, it did not help slow the progression to advanced macular degeneration. So fish oil, in fact, is not helpful, and this is something that was surprising to me because based on some early preliminary other studies, we were thinking that this was going to be helpful for macular degeneration, but it is not. The other major thing that the study was looking at was beta-carotene. In smokers, the original formulation had beta-carotene. In smokers, if you've been a current or recent smoker, it's been shown that high doses of vitamin A or beta-carotene can increase your risk of lung cancer. So one of the points of this study, so in all of my smokers or recent smokers, I do not recommend that they take the beta-carotene, and there's plenty of vitamin supplements out there where they remove the beta-carotene. And so one of the studies, the lutein and zeaxanthine are all in the same class of a carotenoid, and that's what this beta-carotene is. And they found that when they substituted beta-carotene with lutein and zeaxanthine, that was also very beneficial, and it decreased the risk of progression advanced macular degeneration by 18%. So we do have a very good vitamin supplementation for our patients that smoke. Also, they lowered the zinc dose in the supplements, and that also had no effect on progression. And the reason why they did that is some people get a stomach upset from the current amount of zinc in the vitamin formulation. So the current formulation in the ARID study, vitamin C and vitamin E, zinc, and copper are all effective. You should either take a formulation with beta-carotene or the lutein and the zeaxanthine. And we're a little unclear on is adding lutein and zeaxanthine, does that actually help? And if you add it in addition to beta-carotene, in this study they found that it probably didn't help by adding that in addition to the beta-carotene, because sometimes the way these vitamins work is that one can compete with the other. So even adding more isn't always better. And then the omega-3 fatty acids did not help slow the progression of macular degeneration. But a healthy, well-balanced diet is also very important. Dark green leafy vegetables and yellow, orange, and other colorful fruits and vegetables are very rich in lutein and zeaxanthine, and I recommend that all of my patients eat spinach and kale and all those green leafy vegetables if you can tolerate them, because it does help slow the progression of macular degeneration. For the wet form of macular degeneration, we do have medical treatments, and that the main standard of care now is intravitreal injections, where we actually inject a medication inside the eye. And you may have heard of some of these treatments before. Avastin, Lucentis, and Eylea are the three main drugs that we use. Avastin was initially used for systemic cancer therapy, and although cancer and macular degeneration are very different, they are both can be vascular-driven entities. And somebody thought, well, because macular degeneration is vascular, would Avastin help? And they started injecting it into rats' eyes, and they found that, my goodness, it can make these blood vessels regress and go away and stop leaking and bleeding. And so then it's actually started being used off-label. Avastin is not FDA approved for macular degeneration, as many medications are not approved for what we use them for. And so we started using it off-label, and many studies have been done, and these three drugs are basically the standard of care treatment. All of them are in this class of drugs called VEGF inhibitors. And VEGF inhibitors work by blocking the growth of abnormal blood vessels, which stops and slows their leakage. The first drug that was started in 2004 was Macugen, that was approved by the FDA for this condition. And it's not even down here because we really don't use that drug much anymore. And they found that Avastin and Lucentis were much more effective than Macugen, and that has become our mainstay of treatment. So they are made out of antibodies that bind VEGF and inhibit its effect on having these abnormal blood vessels grow and leak. And then Eylea traps VEGF in it, and this drug came out in January of 2012, so that's our most recent medication that we use. These intravitreal injections are not a cure for macular degeneration. They do not cure the condition. This can be a chronic, recurrent condition that can require regular injections. Initially, we typically inject and treat every 4 to 6 weeks, and then we can sometimes decrease the frequency of injections. Sometimes we can get the blood vessels to regress, and then we monitor because it's very common for this condition to recur. There's a significant cost difference between the medications. Avastin is $100, whereas Lucentis and Eylea are $2,000 and $1,700. So there's a huge cost difference between these medications. Fortunately, the risks and side effects are very low. There's a small risk of infection, so we clean your eye with a medicine called betadine to prevent infection. But they're very low, and the goal of treatment is to stabilize the disease over time. Some patients get improvement in vision, others just get stabilization of vision, and unfortunately some just don't respond to treatment. But these drugs have really revolutionized the way we treat macular degeneration. Before, people lost their vision from macular degeneration, and now I have patients that are bilateral macular degeneration that are still 20/20 and requiring injections. There's other treatments that we use, photodynamic therapy, just a brief, you may hear about this therapy. Sometimes we use it in combination with VEGF drugs, and involves injecting a dye into the vein called verteporfin. It's a photosensitizing dye, and then we apply like a cold laser that photoactivates the dye and targets the abnormal blood vessels in the macula. There's also thermal or hot lasers that have been used in the past, and that's not really a treatment we use anymore, but for the photodynamic therapy is sometimes we still use in combination with the intravitreal injections. One of the big questions I get in my practice is, what is a better drug? Which drug should I be using? Should I pay $2,000 for Lucentis or Eylea, or should I use Avastin? And there was a head-to-head trial that showed that Avastin, the CAT trial, that compared Avastin and Lucentis, and their 2-year results were published in May of 2012 that showed that there was no statistically significant difference outcome between Avastin and Lucentis, and when they found that they're both effective therapies for macular degeneration. And then when Eylea was studied, that was compared in the VIEW 1 and 2 studies, and those in those studies, they found out that Eylea was just as effective as Lucentis. So because Avastin is a very cheap drug, I use it because it works, but some patients